Very good morning to all of you. Thank you so much for this wonderful opportunity. I'll keep it very simple. Let's see that atrial fibrillation and heart failure is like a big giant. When heart failure is complicated by atrial fibrillation, probably all the complications are on an increase, and NOAC is one of the modalities to deal one of the complications that is occurring because of both. Why do we need to worry? This is because atrial fibrillation is already present in heart failure patients in almost 20 to 30% of the cases. And presence of heart failure itself will increase atrial fibrillation by 5 times. So that's a reason of concern. Even without atrial fibrillation, stroke is occurring in almost 2 to 3.5% of the cases. And when atrial fibrillation is complicating it, the risk is almost doubled. So that is the reason for worry. This is the data, if you want to just have a look. Irrespective of the type of heart failure, you see atrial fibrillation is significantly present in almost 25 to 50% cases of heart failure. And not only this, when atrial fibrillation is complicating heart failure, all-cause mortality, heart failure deaths, this is increasing, and almost 15 to 20% of the cases will have a stroke. So there is a reason to worry about it. Why it is important for us to understand why this is called a double trouble. The reason is that the vicious cycle of both, they are both contributing to morbidity and mortality together. They are increasing heart failure hospitalization, stroke and embolism. They are also increasing the mortality. And why this is happening, I'll explain in very simple slide, that the loss of atrial kick is going to increase and have an irregular ventricular rate. The patient is going to have or develop a tachycardia-induced cardiomyopathy. There is neurohormonal activation, and definitely there is risk of thromboembolism. All these are culminating into a worsening heart failure and more complications like stroke and all-cause mortality. This works like a continuum. Look at this. On the above you see the stages of heart failure are progressing, and lower down you have atrial fibrillation risk, starting from at-risk atrial fibrillation to pre-atrial fibrillation, and then we have a spectrum of atrial fibrillation that is occurring in heart failure. And look just above that the patient is having an increased risk of stroke as the atrial fibrillation is occurring, and this is what we need to manage. So pillars of atrial fibrillation management includes lifestyle, anticoagulation, rate control, rhythm control. I'm not going to go into the details. My job is to simplify why and when to anticoagulate. So there is high prevalence of coexistence. Additive thromboembolism risk is increasing by almost 2.6 fold, as I clearly outlined. But what is the anticoagulation dilemma? The dilemma is we have to balance between the ischemic and the bleeding risk. So let us start from beginning to make you understand very clearly how it all started. Look at this. Even without atrial fibrillation, OACs were given in heart failure patients, and the initial trials were WASH, HELAS, WATCH and WATSEP. These 4 trials were the landmark trials. What was the conclusion? The conclusion was, even if the patient is not having atrial fibrillation, if you anticoagulate these patients, the risk of stroke, relative risk reduction was 41%. So these patients probably need, in suitable cases, anticoagulation is needed to decrease the stroke risk. This is what the timeline was. What happens when atrial fibrillation is coming? Are we using traditional drugs like warfarin and coumarins? What happens if warfarin is given in patients of heart failure with atrial fibrillation? Look at this, the stroke reduction was almost by 65%. This was shown by the active trial. So we are very sure that oral anticoagulation is needed in patients of heart failure without AF and also heart failure with AF. But there are challenges with VKA. What are the challenges? We all know. In India specifically, very significant less number of patients are going to be in TTR. Time to therapeutic index we are unable to maintain, and if we are unable to maintain, we need to have an alternate. Polypharmacy, the drug interactions, most of our patients who are presenting are unaware of the interactions. Even doctors are unaware of the interactions, and it is difficult to monitor and dose, and this is where NOACs are of great importance. This is where NOACs. So in a country like India, if cost effectiveness is there, NOACs are a great choice. So how it all started with NOACs? NOACs, they were seminal trials. They are known direct. It has been derived from the already occurring trials that showed that NOACs are non-inferior to the VKs from studies which were occurring in 2009 to 2013. And look at this, what were these studies? 4 studies were landmark. We should remember these 4 studies: the Rely, which used dabigatran; Rocket AF, which used rivaroxaban; Aristotle, which used apixaban; and Engage, which used edoxaban. I'll make it very simple for you. Look at this. Now, all these trials recruited patients, almost more than 15,000 patients in each. But they were not direct trials. The heart failure population in each was almost 30%. 30% of these patients were having heart failure, along with atrial fibrillation, of course, and they were very representative of all the types of heart failure. These patients were given NOACs. What were the results when it occurred? The results were, look at this Rely. The Rely trial, which used dabigatran, only in 150 milligram dose, not in 110, dabigatran was associated with lower stroke and lower systemic embolism, but same hemorrhage. The hemorrhage was same. In Rocket AF trial, which used rivaroxaban, again, rivaroxaban was non-inferior to warfarin for again stroke and systemic embolism. So it was comparable, very good. Then we have Aristotle. Aristotle showed that apixaban was superior. It was superior to warfarin in preventing stroke and systemic embolism, and also it caused less bleeding and led to lower mortality. The mortality was being driven by the lower reduction of ICH. And then we had edoxaban. Edoxaban also showed that edoxaban, the patients, it was non-inferior to warfarin with respect to stroke and systemic embolism. So a meta-analysis then was done for all these 4 trials, and what it showed: dabigatran only in the dose of 150 milligram, rivaroxaban 20 milligram, apixaban 5 milligram twice daily, and edoxaban 60 milligram OD. All of them had lower bleeding, 35% reduction in bleeding. All of them had lower stroke, almost 1/3 patients, the stroke was 30% reduction, and the all-cause mortality was less by 20%. So, no doubt that NOACs were either comparable or superior to the traditional warfarin drugs which we are using. Another meta-analysis that was done published in JACC Heart Failure, it again showed similar kind of meta-analysis that showed that stroke and systemic embolism reduction was 14%, major bleeding was decreased by 24%, and even intracranial hemorrhage was decreased by 41% when NOACs were used instead of oral anticoagulants. So, NOACs significantly reduced stroke, systemic embolism, major intracranial and any bleeding, regardless the presence of even heart failure. That was the beauty of this. And this laid the path for the guidelines that came out, and the guidelines were: if a patient is having heart failure and atrial fibrillation, class 1 indication AHA says that you use OACs. If OACs, oral anticoagulation, if the charge was score is high, and NOACs are preferred over warfarin. The evidence, as I clearly outlined, were these 4 landmark trials. The European Society again outlined and corroborated with the same finding that OACs have to be given, especially if the score is more than 2 in men, more than 3 in women, and NOACs are to be preferred over the VK. So this laid the guidelines, and this is how it was summarized, that the score is more, DOACs are the preferred agent. What about Indian guidelines? We had recently Indian guidelines. They very beautifully address the issue of TTR. NOACs, they clearly outline they should be the first line patients of heart failure and atrial fibrillation. And apixaban has to be preferred in renal dysfunction. I'll be talking about it later. And rivaroxaban and edoxaban have a better adherence because of the daily single dosing. But what they saw was something interesting, that time to therapeutic index, if it is maintained, then even warfarin performance was almost equal to the DOACs. And they said that they designed a score which is called the same TTR. This score I have outlined here, which you can go and check out separately, that if the score is more equal to 0 to 2, then dose adjusted vitamin K antagonists are doing very well. If the TTR is maintained, time to therapeutic index is maintained within 70%, more than 70%. But if the score is more than 2, then one should prefer straight away NOAC. So this is what are the guidelines for Indian doctors, specifically in the Indian scenario, if we are using this particular score. So, are we having more evidence beyond historic trials? Let me tell you, there are no direct trials that have been conducted. Yes, more meta-analysis have come. So, this was in 2024, International Journal of Cardiology. We had a very interesting report. In more than almost 2 lakh patients, what it showed was, almost 1,80,000 patients, it showed that mortality, readmission rates, all-cause mortality and ischemic stroke, it was comparable in both warfarin as well as the newer anti-oral anticoagulants. So it was comparable in 2024. But remember, most of the patients were remaining in a very good TTR. That is what is important. The NOAC score over warfarin, if they are the control group, is not maintaining a time to therapeutic index. We had another very beautiful study that was non-vitamin K antagonist coagulation in different types of heart failure. Very interesting. Now look at this. This study gave us an interesting message that the results were varying also according to the type of heart failure. When we talk about stroke and systemic embolism, the results were phenomenal. Almost 29%, 30% decrease in stroke and systemic embolism, specifically in heart failure with reduced ejection fraction. But in mid-range and preserved ejection fraction, it was only 10% or probably a non-significant decrease. Major bleeding was much less in mid-range and preserved ejection fraction, almost 32%, but in reduced ejection fraction, it was only 14%. So, according to the heart failure, the message is that stroke and systemic embolism, the most important subset that is going to benefit is one that is having a reduced ejection fraction. So, it concluded that patients with atrial fibrillation and heart failure, NOACs have a better and probably similar effectiveness than warfarin. But stroke prevention superiority of NOACs varies in different heart failure subtypes. So there are no direct comparisons. Is there any other reason to use NOACs besides just stroke and systemic embolism and mortality? Yes. It is interesting to see that besides warfarin, NOACs are the only drugs that are also reducing possibly neurohormonal activation. And that is why measuring anti-proBNP, the heart failure hospitalizations were relatively less when NOACs were being used. So probably this is what we call as pleiotropic effects, like in statins, they also have a pleiotropic effect. No direct comparison or randomized control trial have compared head-on both the NOACs. That is one of the limitations. The dosing patterns are very clear. I told you that dabigatran in 150 mg twice daily, rivaroxaban 20 mg, epixa 5 BD and edoxa 60 mg. Epixa is a great molecule, but twice daily dosing remains a challenge. Patient factors also affect the outcome. It is very important to understand that bleeding tendency is higher amongst patients with nephropathy. So historically, the trials have excluded the patients with EGFR less than 30, but now they have shown that the mortality is similar across all the substrates. So my message is very clear that no doubt if you are able to maintain TTR, monitor your patient stringently and have that same 2 score between 0 to 2, warfarin is a terrific drug. It's going to give you absolutely same results and it's a very cost-effective drug. Most of our patients are still not able to afford DOACs. But if that is a challenge, then definitely DOACs remain the drug of choice. They should be used. They are one of the molecules of choice that are going to address the double trouble. My message is, eyes are not going to see what mind does not know. So look what is beyond the obvious. We should take care of this. This is one of the pandemics that is occurring in India. And my take-home message is, heart failure, atrial fibrillation are coexisting. They are like brothers and sisters. They're going to corroborate and increase mortality and mortality. Stroke risk is significantly high. NOACs are better and they have a more favorable and they are more effective choice. As I always say in conclusion, that all modalities should be used wisely with clinical experience, because a fool with a tool is still a fool. Thank you so much.
Thank you, Mohit. Thank you very much.